I'm interested in how you communicate to patients because I know that not only do you really work on safely tapering clients off of psychiatric drugs, but there is med management, and I'm sure as a trained psychiatrist, there are some selective situations where you're going to manage the risk benefit profile and communicate to your clients. So I want to address some of the severe risks that's associated with SSRIs. I know you're aware of some of the same scientific literature demonstrating that they increase risk of suicide, self-harm, and violence. I listened to your great interview with Dr. David Healy, who's a renowned expert, former pharma insider on this issue. I think we can all agree that people just are not adequately informed of the risks. Thus, the ethical and legal standard for informed consent is not often met for people who prescribe these drugs. So, how do you describe the risks to people and address this issue of suicide and violence if you believe could be some at least short-term benefit?
Yeah. So, pretty matter of factly, and I'd love for you to kind of challenge me on some of these things. But to me, so one, I'm so different from a lot of psychiatrists in the US. The prescribing guidelines have them as like a first line treatment. I mean, to me, it's only for the people with the most severe depression and anxiety, usually, and more so anxiety, kind of obsessive ruminations, getting to the point where like maybe they're agoraphobic or they can't leave their home. And, these are people where they've attempted to address any other alternative explanations for it, whether it's dietary changes or, cognitive therapies, or maybe, sometimes you just use these medications because the patient can't do those things. They don't have access to them. And it's just like, this is, you're making an informed decision about it. So in terms of the risks, if I was talking to a patient about this medication, I would say, these drugs, they can, they can make people feel worse. I'll tell people they increase the risk of suicide, but I think the most straightforward way to explain this to people is there's a proportion of people and it makes them feel more agitated and depressed. If this happens to you and it's coming out of the blue and doesn't seem like it's anchored to stresses in your life, you need to stop the drug immediately. I think that's the easiest way to explain that risk. That one actually doesn't bother me that much because I watch my patients very, very closely and I communicate with them a lot. So that one stops. I mean, if you pick up on that one, you stop the drug, they're better in 2 days, sometimes a little bit longer, but quickly. The problems with tolerance and dependence, again, not as concerning for me. I mean, and this is my bread and butter. I help people with this. If I can bring someone down off a drug in a slow way, that's okay. That's most of the time, the majority of the time, they're going to be just fine. The one that I have a real difficulty with is PSSD, and this was the one that really kind of changed things for me. That really kind of pushed it over to the like, I'm almost never going to use this drug because what I would have to tell someone is there's a chance that this drug is going to make you worse permanently, or for several years if you do this. There's no way I can tell you whether you're going to get this risk. And so you're going to have to weigh this against, how you're feeling now and what may be just a very modest improvement in your condition. So with something like PSSD, I mean, it really, really makes it hard for me to feel comfortable prescribing antidepressants unless the person is just completely debilitated by depression and anxiety.
Do you believe this has the opportunity to create long-term harm for a developing teenager who's still trying to determine their own identity, their own sexual development? Can it permanently impair that?
Yes, I think so. Yeah.
And these are some of the things that I've just been killed for on social media because, there's situations that, people come into my practice, like a 20-year-old who has been on an SSRI for 10 years and they identify as asexual. And they were never warned of the risks. And their identification with asexual is they never developed any sexual attraction or any libido for either sex. And they don't see anything necessarily wrong with it because when they started the drug, they were prepubescent. I mean, they don't even really understand it. But there is an emotional detachment to them and they've identified with this asexuality as if it is something a part of them. And there's a lot of offense taken when you bring up the possibility that this is drug induced.